Good afternoon, gentlemen. Let me introduce in brief about myself. My name is K.V. Ramana, and I've been taking care of the Asia region for hetero for various therapies and markets across Asia. So basically, hetero is a company. Let me introduce hetero as a company. Hetero is a company which is pioneer in active pharmaceutical ingredients across the globe. And we have been supplying our APIs to many of the international companies throughout, and through which we are in various therapies, including the HIV, anti-cancer segment, cardiovascular segment, and also in various other therapies like respiratory and anti-diabetic as well. So since the topic is more HIV related, so let me have this opportunity in straight getting into the topic that today, if we are proud to claim as a hetero that we are a company which are every fourth patient in the globe is on the hetero drugs. So this has been possible because we have not only the reach to the patient through the various markets, whether it's directly or through the various global funding agencies. Having said this, we have a complete portfolio right from the single molecule to the fixed dose combinations as well. So we physically, through our own teams, we have been present in more than 50 markets, but our presence has been there in more than 140 countries. So this is one of the reason why hetero stands out. Also, it would be good to say that hetero stands out also because for the reason that we are API backward integrated company, and then through which we not only will be able to give a complete portfolio, but also will be able to give a quality product and then at a very economical price as well. So which is an advantage with a company like hetero. So through this, let me let Dr. Shyam introduce the guest speakers who are there today, Dr. Joseph Perrie, and then Dr. Rosanna Ditango, who is the chairperson and moderator. So over to you, Dr. Shyam.
Thank you, Mr. Ramana. I am Dr. Shyam Akku, Head of Medical Affairs for Emerging Markets at hetero. On behalf of hetero, I would like to welcome our chairperson and moderator for today, Dr. Rosanna Ditango, our guest speaker, Dr. Joseph Perrie, and all the doctors and delegates to today's session. The HIV disease landscape has been evolving, largely due to advancements in treatment and availability of newer drugs. Today's session focuses on these aspects and its clinical implications in managing HIV patients. I'd like to give a brief introduction about our chairperson and moderator for today, Dr. Rosanna Ditango. Dr. Rosanna Ditango has a Doctor of Medicine from FEU Nicanor Reis Foundation, residency training in internal medicine at National Kidney and Transplant Institute, and fellowship training in infectious and tropical disease from UPPGH and RITM. She is a fellow of Philippine College of Physicians and Philippine Society of Microbiology and Infectious Disease. She has undergone training on clinical management of HIV at Cornell University, New York, and postdoctoral fellow at the Department of Global Health and Epidemiology, Graduate School of Medicine, Hokkaido University, Japan. She is the head of RITM's AIDS research group. She is a principal investigator for Treat Asia and Asia Pacific HIV Observational Database Study, and the principal investigator of the HIV incidence study among MSM and the pilot study on PrEP among MSM in Philippines. Current research includes demonstration research on HIV-HCV co-infection and continuum of HIV care for MSM in Cebu. She is the course director for various training programs on HIV and AIDS management and member of the technical working group of the AIDS, National AIDS STI Prevention and Control Program of the Department of Health and Development of National HIV Management Guideline. She has got numerous publications in peer-reviewed journals on HIV treatment-related researches. I'd like to give a brief introduction about our guest speaker, Dr. Joseph Perriens. Dr. Joseph Perriens is a Belgian national. His educational background includes MD from University of Ghent, Belgium, Diploma Tropical Health and Hygiene from Institute of Tropical Medicine, Antwerp, Board Certification Internal Medicine from Belgium, and PhD University of Ghent from Belgium. Joseph Perriens is an international public health expert with over 25 years of track record in senior positions in the WHO, UNAIDS, and the Belgian Development Corporation. In the early days of HIV epidemic, he worked for slightly over a decade in HIV-related clinical research in Africa and Asia. From 92 to 2015, in UNAIDS and later WHO, he was variously team leader, director, and later coordinator for HIV treatment and access to HIV-related drugs and diagnostics, and responsible for HIV drug resistance surveillance. After retirement from WHO in 2015, he continues to work as a consultant with focus on access to medicines and health program evaluation. From 2016, this includes working with Hetero Labs Limited, the second largest producer of ARVs globally, as strategy advisor for the access markets. Thank you, and I invite Dr. Rosanna Ditango to talk about the antiretroviral therapy in Philippines.
Good afternoon. I will be giving a brief summary on antiretroviral therapy in the Philippines. From January 1984 to September 2020, the cumulative number of HIV seropositive cases reported to the Department of Health was 80,434. For more than a decade now, MSM has been driving the HIV epidemic in the country, and it is for this reason that 94% of infection were reported among males and 80% of whom were MSM. In terms of treatment, 95% of people living with HIV are receiving treatment using the first-line regimen. And please note that the policy in the Philippines is treat all. It means regardless of the immunologic status or CD4 count and clinical stage, treatment is started, and all treatment is free of charge. Our first-line regimen consists of single tablet regimen of lamivudine, tenofovir, and efavirenz. Next slide, please. An optimized regimen is combination therapy that is effective, well-tolerated, or with minimal side effect, with very few drug-drug interaction, and has a high genetic barrier to resistance so that there would be less chance of the development of treatment failure, is affordable, and can be used in all types of patient population. An optimized regimen is essential in the public health approach to scale up of treatment. However, there is really no perfect optimized regimen. And an optimized regimen is very essential in resource-limited countries or areas because usually in these areas, a public health approach is usually done to scale up therapy. And in resource-limited area, an optimized regimen is usually dependent to access to this ideal regimen. In the Philippines, by October 20 this year, and up to December 2021, the government plans to introduce tenofovir, lamivudine, dolutegravir as a single regimen tablet as a first-line therapy. So the first phase of this introduction will start October this year up to December 2021. So for this first phase of introduction of TLD, all eligible ART-naive adult and adolescents and children who are at least 30 kilograms, excluding those who are on rifampicin-based regimen for the treatment of tuberculosis, will be started on TLD. Other population that are eligible for TLD initiation during the phase 1 are those patients who are receiving tenofovir, lamivudine, and efavirenz and are experiencing severe adverse event to efavirenz. And the third population that are included in this phase 1 introduction will be patients who are experiencing treatment failure while on zidovudine or abacavir-based initial regimen. So that is the current status of the antiretroviral therapy in the Philippines and the moving forward plan as far as the introduction of the new first-line regimen, which is the single tablet of tenofovir, lamivudine, and dolutegravir. Thank you.
Thank you, Mrs. Chair, and welcome to you, ladies and gentlemen. First, my disclosures. I'm a strategy advisor for Hetero Limited, and I also did evaluate a number of grants for Unitate as a consultant for Procella Partners Limited. I have no other disclosures to make. Now let's dive in the presentation. It will cover changes of antiretroviral treatment, antiretrovirals and HIV prevention, and managing advanced HIV infection. This slide shows you changes in antiretroviral treatment, the 2019 WHO recommendations. In the small ovals, you see the main changes. WHO recommended that dolutegravir should be the preferred companion drug for tenofovir, diproxyl fumarate, and 3TC in first-line treatment for all patients, including for women of childbearing age. WHO recommends that women can be prescribed dolutegravir if they have been fully informed of the potential risk of neural tube effects when using dolutegravir at the time of conception or in the first trimester. The alternative first-line regimen includes efavirenz 400 milligram instead of the earlier recommendation to use it at a dose of 600 milligram. This regimen is recommended only when the primary resistance to non-nucleosides is less than 10% in naive patients. Finally, tenofovir alafenamide is shown on this slide for special circumstances. This is for people with established osteoporosis or renal failure only. Next is the, yes, I need to change the slides. We come to the realization that when WHO recommends a policy changes, those policy changes take time to be translated into national recommendations. I lifted out of the 2016 WHO recommendations three important recommendations. The first one being to treat all people with HIV infections, regardless of CD4 cell counts. The second being to shift everybody to dolutegravir in first-line treatment, and the third being to monitor antiretroviral treatment with viral load. As you can see, the uptake of the treat all recommendations is the one that got biggest traction by the end of 2019. 131 countries had adopted this recommendation out of 148 low and middle income countries. The transition to dolutegravir was slower. Back in 2016, the manufacturers still had to scale up their production capabilities and had to obtain regulatory approvals for dolutegravir in many countries. And that made supply of dolutegravir constrained. And then countries had to retool their treatment programs, they had to educate the prescribers, they had to inform the patients, and this took time. And as a consequence, the uptake of this recommendation in country policies has been slower. At the end of 2019, 1/3 of low and middle income countries had not adopted this policy change yet. And viral load monitoring, even if it started from a higher baseline, takes also more time. At the end of 2019, also 1/3 of low and middle income countries had not adopted this recommendation. And this is because determining or testing for viral load is difficult when you use central laboratories and still costly when you use point-of-care technology. And at the same time, there is a lot of pressure to treat more patients and the budgets have not been increasing. So when confronted with more demand for treatment and a limited budget, the preference was often given to treating more patients rather than improving monitoring. This slide shows how these policy recommendations and implementations work out in real life, because policy is one thing and implementation is quite another challenge. In the Philippines, which is the situation shown on this slide, you have as a policy recommendation to treat everybody with HIV infection. But the reality is that up to half of all new patients are still diagnosed with advanced HIV infection, that is less than 200 CD4 cell counts. And the first line treatment regimen in the Philippines is still dependent on the use of efavirenz. A policy shift is imminent, it is under discussion, but implementation challenges do lie ahead, including uncertainty among the prescribers about whether this is the right thing to do, and perceptions about the clients that basically they might prefer to stick basically with the devil they know, especially when they feel well and are virally suppressed. Monitoring of viral load for treatment monitoring purposes is recommended in the Philippines for a long time already. The policy is there, but at the end of 2019, the Philippines could not inform WHO what the viral, WHO and UNH, what the viral suppression rate was among their treated patients, which indicates that there might still be implementation challenges or reporting challenges. So things are not as simple as just issuing a policy document. It requires a lot of work, and it requires not only work on the logistics, but it requires dealing with uncertainty. Why is moving to dolutegravir so important? The reasons are listed on this slide. This comes from the WHO systematic review of the evidence, and you see that dolutegravir is better, or probably better, or comparable in a lot of dimensions. For a public health perspective, HIV drug resistance is probably the most and overriding consideration, because if primary resistance is above 10% and you treat people with efavirenz, when they have non-nuc resistance, you are giving them dual therapy, which is suboptimal and will generate more resistance, this time to the nucleoside component, the backbone of your regimen. And nobody can afford to have this challenge that might make antiretroviral treatment, as we know it, impossible in the future. The other reasons have more to do with the individual experience by the patients. Less side effects means less treatment discontinuation. Viral suppression might be faster, and the neuropsychiatric side effects are likely less with dolutegravir, even though for sleep disorders dolutegravir and efavirenz are somewhat comparable. And then lastly, on this slide, you see two areas of uncertainty. It is body weight gain on one hand and the effect of dolutegravir on neural tube effects. And because uncertainties are important in the mind of people and should be taken into account in decision making, I will now deep dive in the data that underlie the orange lettering on this slide. Antiretrovirals are associated with weight gain. We all know this from the early days of antiretroviral treatment, when we started treating patients with advanced HIV infection with antiretrovirals. People literally stood up from their dying bed, they put on weight and they returned to health. And we also now know that survival benefit occurs when people living with HIV that are underweight put on more weight and are nursed back to normal. Antiretrovirals, on the other hand, are associated with lipoatrophy and lipohypertrophy. We do remember, at least I do remember, Crixivan belly associated with indinavir. I do remember lipoatrophy and lipohypertrophy associated with D4T. And this has also been associated with idovudine. So it's important to clearly define what is the best of the option when considering weight gain while people are taking antiretroviral therapy. And let's also remember that this happens often in an environment in which people are obese. 39% of all adults globally were overweight in 2016, and 13% of adults were obese. And in the United States, 50% of adults starting antiretroviral therapy are overweight. So antiretrovirals are used today on an obesogenic environment, and that is something we need to take into account when looking at individual patients and informing treatment choices. Informed treatment choices need to take into account whether drug and which drug are worse and which ones are better. And it is a fact that greater weight increases are associated with the use of integrase strength inhibitors, more with integrase strength inhibitors than with protease inhibitors on non-nucleosides. This was shown in randomized controlled trials, a pooled analysis of 8 randomized controlled in North America, a major observational study, over 22,000 patients, shows changes in the same directions with people using integrase inhibitors putting up, increasing their weight on average with 5.9 kilos, when with non-nukes the weight gain was 3.7 kilos and protease inhibitors 5.5. While showing changes in the same direction, this you also need to realize that there is a major difference between these two slides, between randomized controlled trials and what happens in real life. In the randomized controlled trials, people are observed and coached and followed very, very closely. And in observational studies, well, this is real life and the follower might be less closely. And then also people in randomized controlled trials tend to be more health conscious because they wouldn't volunteer for participation in the trials if they were not so concerned about health. And then other factors are likely at play too. And one of those factors is gender. This was clearly illustrated in the ADVANCE study. The ADVANCE trial was conducted in Southern Africa and compared dolutegravir with efavirenz on one hand and compared shifting from tenofovir fumarate to tenofovir alafenamide. And what you see is that in this study, the weight gain observed among men was like in the observational studies in the United States, about 5 kilos with TAF and dolutegravir, about 4 kilos with tenofovir fumarate and dolutegravir, which is bad enough. But when you look at women, the weight gain was significantly higher and reached 10 kilos when TAF was combined with dolutegravir, which shows that gender is an important dimension in the weight gain equation. And as weight gain relates to hyperglycemia and diabetes, let's also have a look at what happens with glycemia in treated patients. This slide is from the African cohort study, over 3,500 people in 4 countries. And it looked at the development of hyperglycemia among people taking non-tenofovir and dolutegravir containing regimens, and people taking the TLD regimen, which contains dolutegravir. And as you see that both in the unadjusted and in the adjusted analysis, the incidence of hyperglycemia was not statistically significant between those 2 groups. But what you also see is that among people using dolutegravir, there was a tendency to have more hypoglycemia, which did not reach statistical significance. If you blow up the sample of this study to like a factor 10, this difference might reach statistical significance. It's also important to observe that in this study, the hypoglycemia cases were often mild, and that no cases of severe symptomatic hyperglycemia were documented. Now, what does WHO think of this, and how are we going to deal with these observations when it comes to the situation where we will be in front of a patient and have to prescribe something? WHO decided 3 things in this particular arena. First, it decided to recommend TAF, or to reserve TAF, only for people with osteoporosis and impaired kidney function. Then, because of concerns about weight gain, dyslipidemia, and because TAF cannot be administered with rifampicin. And further, with TAF, there are still knowledge gaps in pregnancy and TB co-infection, because most of the studies with TAF were done in the United States and Europe. Next, WHO changed its recommendations on toxicity monitoring and patient monitoring while on antiretrovirals. The recommendations, the full recommendations, are on the right-hand side, and I know that you cannot read it, but it's important to note on the left-hand side, data were included to specifically monitoring weight gain, that's in the top panel, and blood pressure and laboratory results, glycemia, glycosylated hemoglobin, and lipids. And this is important because it will generate information from automated patient monitoring systems on large cohorts, and it will give more confidence in the long term about how serious these side effects are and whether this leads to additional mortality or unmanageable morbidity. The third decision made by WHO is here, and it was to stick with dolutegravir and stick with dolutegravir for everybody, including for women. And this is informed by the long-term follow-up of the CEPAMO study, the data on neural tube effects from the antiretroviral virals in pregnancy register, and data from Brazil, which all document that the incidence of neural tube effects is not as high as people thought it might have been back in May 2018, when the signal was first detected in Botswana. The long-term follow-up of the CEPAMO study shows that the incidence of neural tube effects is less than 0.2%, less than 2 cases in 1,000, which is not statistically different of the incidence among people using no dolutegravir or using efavirenz at around conception, or indeed not even among HIV uninfected people. Still, it's a little bit higher, and this is why women need to be told about this slightly increased risk. But on the other hand, the outcomes of the women using dolutegravir for their own health and for the health were much better for other dimensions like survival, side effects, and pregnancy outcome. And this swung really WHO in the direction of recommending dolutegravir for women, while informing them that there might be a little problem there, so that they could make an informed choice. The WHO recommendation to shift to a lower dose of efavirenz was basically a no-brainer, because on this slide, and you'll run quickly through it, on all dimensions, efavirenz 400 was either better or comparable to efavirenz 600. And again, this regimen is only recommended when primary resistance to non-nucleosides is less than 10%, because we do need to manage the emergence of antiretroviral drug resistance. The transition for people, for adults and adolescents, to dolutegravir, therefore, is the best option we have for a public health perspective and also for individual case management. And doing this is and recommendations on how to go about it by WHO are on this slide. It says that people who initiate antiretroviral therapy should use dolutegravir from day one, at a higher dose if they have also tuberculosis, but do use dolutegravir. It is a bit more complicated for people who are on antiretroviral therapy already with tenofovir, lamivudine, and efavirenz, as is the case in the Philippines. If patients are in virological failure, it's not really a problem. You shift them to zidovudine, 3TC, and dolutegravir. That is, you use dolutegravir, which has better treatment outcomes. But if viral load is suppressed, or if you don't know, then basically the shift could be done taking into account other factors. If you don't know what viral load is, by all means test your patient and make an informed decision. But when viral load is suppressed, other dimensions are important in decision making, and that is, first, whether you can get your hand on the drug and whether your supply is secured, whether the drug is really available, and whether your patient is willing to go along. And then, and in the end, WHO recognizes that this is so much informed by local and logistical factors and preference among the clients that in the end it decided that countries should have the last word in their national treatment guideline development. And I think that this is being debated now in the ongoing revision. What the future might bring is on this slide, because even when we walk into a dolutegravir transition now, we do know that dolutegravir is not the magic bullet and is not perfect. Therefore, it's important that innovation in antiretroviral treatment continue, and we have cabotegravir, rilpivirine coming along as a long-acting injectable in phase 3 being completed. Dual therapy with dolutegravir and 3TC or rilpivirine is commercially available and approved in the US and in Europe, but is not recommended by WHO yet because of concerns about the use with TB drugs, with hepatitis B, with baseline resistance, and the use in advanced HIV infection. More data will inform the position of WHO on the use of these dual combinations. Islatravir and doravirine is in phase 3, is probably going to come out in a year or maybe 2 years from now. Fostemavir and ibalizumab were approved by the FDA and EMEA for heavily pretreated patients with multi-drug resistant HIV infection, and the capsid inhibitor by Gilead is in the pipeline and looks good because with subcutaneous injection, they had therapeutic levels for over 24 weeks, which opens the potential of very long-acting treatment. And broadly neutralizing antibodies are also in the pipeline. They have the same potential, but they're in early clinical development, phase 1 and phase 2. Now let's move to prevention. And I'm looking at pre-exposure prophylaxis here because this is the area which we have some changes. WHO recommended pre-exposure prophylaxis for people at substantial risk of HIV infection in 2015, and in 2019 it released its earlier recommendations, originally formulated to 2017, that people should consider event-driven pre-exposure prophylaxis with TDF and FTC or TDF-3TC for men who have sex with men. The scheme is here. It is 2 tablets, 24 hours, well, 2 to 24 hours before sex, then 24 hours later, and another 24 hours later, yet another tablet. This regimen was shown to be highly effective in the hypergay and the Prescure studies, and is usable by for men who have sex with men. It's not usable for women and for transgender women because the concentrations of tenofovir in the vagina or in transgender women are too low because of the interplay with estrogens. The tissue levels don't build up quickly enough to be protective for them. But for MSM who can plan the sexual encounters or who have infrequent sexual encounters, this might be a very good solution because it offers them more flexibility, less exposure to the potential side effects of these drugs, and it enables them to fit it in their lifetime. In 2019 also, a Gilead-sponsored study showed that TAF and FTC was as effective as TDF with FTC, the advantages being smaller pill size and less risk of bone and kidney abnormalities. But the downsides are weight gain and increased lipids. And in places where TAF is not available or is not available as a generic, which is nowhere basically today, there might be a very significant cost differential too. In prevention, there was also major news this year in that cabotegravir administered once every 2 months was more effective to prevent HIV infection among men who have sex with men. And 2 weeks ago, it was confirmed that this was also the case among women at high risk of HIV infection in sub-Saharan Africa. On the left-hand side, you see the difference in incidence between PrEP with TDF and FTC and cabotegravir among MSM. And on the right-hand side, you see just the data with no graph because the data is not published. This comes from a press release, but the data is very exciting because it opens a new venue for HIV prevention that we didn't have before and might be very useful for people at high risk of HIV infection. Next is a new development that would empower women to prevent HIV infection. A Dopamine vaginal ring was demonstrated in 2019 to reduce the incidence of HIV infection among women at high risk of HIV infection in randomized controlled trials by 27% and with up to 63% in an observational study. This product is very stable, has a long shelf life, was approved by the European Medicines Agency in July 2020, and regulatory approvals are ongoing, initiated by the International Partnership for Microbicides. In the future, this ring might include other antiretrovirals and contraceptives and might offer options for women who cannot take tablets and who will not use intramuscular injections. So additionally, it's about choice. Choice is important for the management of HIV infection, also by people at high risk of acquiring it. The prevention pipeline with antiretrovirals is not empty. New formulations of cabotegravir are in this pipeline. Contraceptive combinations with tenofovir and TAF are in the pipeline. Implants with TAF are in the pipeline. Islatravir by Merck was shown to produce sustained effective levels when using an implant for up to 12 months in a modeling exercise released at CROI 2019, but of which we have seen no further data. But importantly, last week, Merck and Bill Melinda Gates Foundation announced that they will start a phase 3 study of oral islatravir administered once a month among cisgender women in South Africa for HIV prevention, which is very encouraging news. The capsid inhibitor by Gilead might also be developed for prevention indications, and broadly neutralizing antibodies should be useful for this indication as well. Finally, I want to close with one slide on managing advanced HIV infection. This was the only thing we could do when in the early days of HIV infection, and has slipped a little bit in attention from our radar screen as antiretrovirals occupied the front of the scene. But new technology makes managing advanced HIV infection easier, and new guidelines support that and a package of interventions should be offered to everyone presenting with advanced HIV infection. And this new and expanded package includes screening and diagnosis for tuberculosis with the expert diagnostic system in symptomatic patients, and urine lateral flow lipoarabinomannan assay for people who are sick or who have a CD4 cell count of less than 100. This would detect disseminated tuberculosis more efficiently and is a breakthrough in TB diagnostics. People with less than 100 CD4 cells should also be screened for antigen, for cryptococcal antigens, and should be offered fluconazole preemptive treatment without getting to a lumbar puncture with fluconazole if the cryptococcal antigen test is positive. Further, HIV infected people with less than 350 CD4 cells should be offered cotrimoxazole prophylaxis, and they should be offered cotrimoxazole prophylaxis if they live in a high malaria or severe bacterial infection incidence area. And then all people should be offered TB preventive treatment at any CD4 cell count. Finally, antiretrovirals should be started quickly, immediately, if at all possible, or within 7 days. Unless people have tuberculosis or cryptococcal meningitis, of which treatment needs to be initiated for some time to prevent the development of IRIS. And finally, people need to be offered adherence support, a lot of it, because starting antiretroviral treatment plus infection control plus TB preventive therapy plus maybe preemptive therapy for cryptococcal meningitis in one go, in one consultation, is a big challenge for somebody who is HIV infected, diagnosed at the 200 CD4 cell count, but still feeling healthy. And this would be very big of a challenge for everybody, even if you were not HIV infected. But there's a lot of things people need to deal with when confronted with an HIV diagnosis, as we all know. I would have hoped additional guidelines on Kaposi sarcoma, on toxoplasmosis, on other opportunistic infections from WHO. I hope it will be forthcoming, but this package needs to be implemented, and it needs to be budgeted in the planning of clinical services. It needs to be pushed to the patient, because this will save their life. And With this, I would like to close my presentation and hand over to the chair. Thank you very much for your attention, and I'm looking forward to your questions. Oh,
Thank you very
Mrs. Chair, sorry, I just forgot to mention something. When I was presenting the first-line treatment regimens in my earlier slide, and they were highlighted with a yellow TLD and a yellow TLE 400, I did not mention that WHO recommends that these treatment regimens should be administered as a single tablet containing all 3 drugs in one go. And I know that these formulations are presently not available in the Philippines, but I would like to mention, because this is after all a hetero-sponsored symposium, that hetero will be releasing this formulation very soon for the TLD formulation. And we hope that this will be major support to the programs in the Philippines. Thank you very much.
Thank you very much, Dr. Joseph Perrier, for the very comprehensive lecture. You did not only give us an update regarding the current recommendation and treatment, but also gave us a glimpse of what's in the pipeline as far as HIV treatment and prevention is concerned. Maybe before we close, I would just like to ask your prediction regarding the role of dolutegravir on its impact on treatment as prevention, as I think this is really the reason why it is being pushed by WHO because of its high genetic barrier to resistance and good profile of safety profile of dolutegravir. Do you think it would really make an impact on treatment as prevention?
That is very hard to say for me, because treatment as prevention is also dependent on the amount of coverage you have with antiretroviral treatment in your population. And in the Philippines, certainly only about half of all people with HIV infection are presently being treated. So the relative difference between, well, what dolutegravir would do or efavirenz would do is slightly less important than improving the coverage of treatment in the first place. So yes, from a virological standpoint and for for treatment adherence, we can hope that it will contribute to prevention, but I think that we will see at the end of the day that the net effects will be rather limited. Medically speaking, yes, but well, from an epidemiological perspective, it's possibly not all that big.
Thank you very much, Dr. Perrier. So in behalf of the Philippine Society for Microbiology and Infectious Disease, I would like to thank Dr. Joseph Perrier. And also I would like to thank Camber Pharmaceuticals for organizing this very good symposium on HIV treatment and prevention. So thank you very much for all who participated in this scientific session.